Okay, good morning, and thank you for attending our webinar series. Today, we're excited to have one of our consultants, Tiffany Johnson, doing a presentation on public health and telehealth, sort of a match made in heaven, and how um, those two forces have come together to help us be able to address the pandemic in a better way, and sort of how telehealth has helped in the public health arena. Tiffany Johnson holds a master's degree in public health and has worked in healthcare and public health organizations for the past 6 years. Some of her passions include improving access to and quality of medical care, improving patient outcomes, and healthcare optimization. She currently serves as the secretary for the medical care section of the American Public Health Association, and is also on the executive board for Home State's Public Health Association, the South Dakota Public Health Association. I almost made you a South Carolinian there, Tiffany. She currently works at the University of Nevada, Las Vegas School of Medicine, and she's been a consultant with Blue Cirrus since late last year, and we're happy to have her on our team. Tiffany, I'll turn it over to you to tell us about public health and telehealth.
Thank you, Michelle. I'm really excited to be here today and to kind of bridge some of the gaps between telehealth and public health and talk about how they've been working together for the past year. So first, I want to start off by talking about what public health even is. Public health is a concept that's both very easy and very difficult to define. In broad terms, public health is just that. It's a field that focuses on the health of the public. In this field, our goal is to improve the health outcomes of populations rather than just one individual. So when you go to the doctor is focusing on just you, the sole patient during that appointment. But the patients, quote unquote, of public health professionals are communities at the local, state, tribal, national, and global level. The definition of public health can become difficult because there's just so much that influences people's health. Things that you would never even think of, like the location of grocery stores, your zip code, the job that you have, legislation, your level of education, or even the amount of crime in your neighborhood can all affect your health. For these reasons, public health encompasses all types of industries, from environmental, agricultural, food, civil rights, politics, law enforcement, public transportation, and of course, medical care. Public health is definitely in its 15 minutes of fame right now, thanks to COVID. And now pretty much everyone is familiar with even some of the most basic public health or epidemiological concepts. So public health wasn't always a household term, but it's definitely been around for a long time and has been an unsung hero for many years. The first major epidemiological investigation was recorded and has been a staple in public health history, and it was actually way back in 1854. A doctor noticed cholera outbreaks throughout his community in London, and at that time, most people believed that disease was caused by bad air or unknown causes, and most people just accepted illness as a random act. But John Snow hypothesized that disease had an etiology. It wasn't just a random fluke instilled on some unlucky person. So when he began to notice a significant amount of cholera diagnoses in the cramped and dirty parts of his neighborhood, he decided to test his hypothesis. This map that you see here on the screen is actually a copy of the original drawing that Snow created to help track cases of cholera in his community. He drew the layout of the city and started tabulating the number of cases. And you can see these cases marked here on the map. The smaller squares like these up at the top and kind of off to the side denote fewer cases of cholera. And the darker, longer rectangles like these ones and these over here denote higher rates of cholera. So if you take a look in just about the middle of Broad Street, which is right here, you can see the longest, darkest, most prominent rectangle. So that denotes the most cases in the entire community. Snow knew something in that area was likely the cause of the high rates of cholera. Through his tracking and interviewing of patients, he discovered that every single case had either used or had been in contact with somebody who had used the water pump. And can you guess where that water pump was located? Right in the middle of Broad Street, right next to this biggest, darkest, most prominent rectangle. And if you have a good copy of this map, it actually says pump right there. So in hopes of alleviating the epidemic of cholera, Snow removed the handle to that water pump so people would no longer be able to use it, which inevitably stopped the outbreak and essentially founded epidemiology as a true science that could help improve people's lives by tracking and investigating disease. I know this slide is a little overwhelming at first, but that was my intent. Even before public health was a household term and before COVID-19, you were being inundated with public health campaigns, and you may not have even realized it. Okay, so 1854, John Snow, cholera, and now we're in 2020 and we're combating COVID-19. A lot of years have gone by in between then, but what else has public health done? As I mentioned, this field has been an unsung hero. If people hear about high rates of disease and outbreaks or deaths, then our public health measures aren't working. So most of our best work typically goes unnoticed. Some of the top 10 public health initiatives have been vaccine preventable diseases, which we're all kind of seeing to fruition right now with the COVID vaccine rollout. But one of the most notable successes with vaccine preventable diseases has been the near eradication of polio. I think currently Pakistan and Afghanistan are the only countries who have not eradicated polio, and their cases are in some very rural and mountainous populations. Prevention and control of infectious diseases like yearly flu shot campaigns, STD prevention, hand hygiene, and sanitation are also huge public health initiatives. Tobacco control has been another huge public health initiative. I don't know if many of you remember those commercials years ago with cancer survivors who had lost portions of their face or who had tracheotomies from smoking or chewing tobacco. Advertisements like those, the Surgeon General warnings that we see on cigarette cartons are all public health initiatives as well.
Tiffany, can I ask you a question since you're talking about that? What do you, I do remember those commercials, and I think, and they were very powerful. They were scary and powerful. Do you think that with the vaccine for COVID, do you think we need to have something similar to that today to help people understand the benefits of getting the vaccine?
Yeah, I think that, kind of a shock factor is always a really great form of advertisement, particularly in public health, especially with something like with COVID, typically the healthier populations aren't having as difficult of a time as some of our more at-risk populations. But advertisements like that really kind of give you a shock factor are really great forms of advocacy in public health. But unfortunately, like many things, that all comes down to funding, of course, if there's funding to make commercials and things like that of that nature.
Thank you.
And I would be amiss to not recognize that a significant amount of public health initiatives are intertwined with the medical field. Reducing adverse outcomes in maternal child health through prenatal care, family planning, social welfare programs, advocacy against pregnant women drinking, and the shift to birthing in hospitals as opposed to at home has really improved the health of many moms and babies. A lot of efforts also put into reducing cardiovascular disease and cancer through screening at-risk populations and advocating for healthy lifestyles. So these are just some of the top 10 public health successes, but there are many, many more successful public health measures out there. And it's also important to note that public health measures don't need to be national campaigns. Small initiatives within communities or organizations can be extremely impactful as well. Even advocating for safe driving practices to reduce automobile accidents is certainly within the wheelhouse of public health. So I've made a pretty good argument that public health is very broad, yet can be specific, and that it has very impactful outcomes. But how do we know exactly what to target? What actually goes into your health? If I were to ask you what makes you healthy, you might say a good blood pressure or a healthy weight or a good BMI. But really, there's just so much more that goes into your health than those personal statistics. And some of those factors may even be out of your control. Social determinants of health is a really popular phrase in public health. And that phrase really encompasses everything outside of medical care that influences your health, like your socioeconomic factors, the physical environment that you live in, and your health behaviors. So if you add up all those percentages right here, those account for nearly 80% of your health, and you really probably don't even think about them that often. I like to think of social determinants of health as being the factors outside of your doctor's office that influence your health, and public health really shines a light on those. So I'll just work through some examples of how these could influence your health. I'll start with education. Typically, those who have had some type of education, whether that be graduating from college or even high school, are better able to secure better paying jobs. Level of education can also be indicative of how well a person may be able to understand medical terminology or medical jargon from their healthcare provider. If a person has never had any formal education, they may not understand why adhering to a strict diabetes medication regimen is crucial, or why it's so necessary to have a healthy, balanced diet. So it's really important for healthcare professionals to keep this in mind when they're talking to patients. Similarly, employment and income matter. If a person's employed, they're more likely to have money to seek medical care, or they may even have insurance through their employer compared to those who are unable to work. Your environment and social circles are also very important in terms of your health. Are you able to afford safe housing? Is your house free of lead paint? Do you have access to clean water? Do you have access to a grocery store, or do you live in a food desert? Do the people that you live or socialize with use drugs or alcohol in excess? Answers to those types of questions can tell us whether you're part of an at-risk population for certain diseases or conditions. For example, those with risky sexual activity or IV drug use may be considered at-risk populations for HIV. Understanding how social determinants of health influence the health of populations is important because this allows us as medical professionals to identify at-risk populations or populations, races, gender, etc., that may be more disproportionately affected by certain diseases and thus have gaps in their healthcare. So in this past year, we've all been a part of a huge public health crisis, and we've seen how difficult it is to get everybody on the same page, whether that's globally, nationally, or even within smaller communities. In order to make big impacts in population health, there has to be an evidence-based, systematic approach to doing so. For this reason, frameworks are a huge asset in public health, and this one shown here was developed by the CDC, and it outlines the 10 essential public health services. And it really shows the basic foundation of a lot of our initiatives. First and foremost, you have to know what the population's needs are before you can figure out how to address those needs. This can be done through community needs assessments, research studies, chart reviews, as well as other modalities. Once you know what the population needs and have data or research to back up the policy, program, initiative, whatever you're trying to make happen, the process moves on to policy development. So if you're trying to improve hospital readmissions in your facility, you may be working with a committee and executives at your hospital. But if you're trying to make a public health policy or law, say about insurance coverage or abortion laws or pharmaceutical prices, you're likely going to be working with somebody at the state or legislative level to draft a bill. If it's an initiative that's a little more low-key, maybe like just increasing physical activity in your community, you're likely going to spend a lot of time communicating and educating your community about why increased activity is important, rather than just implementing a formal policy. And I do want to highlight the policy development section of this framework because in these past year and a half, 2 years, we've really seen how much the political atmosphere can influence health outcomes. Public health professionals in particular are very passionate about breaking through to people in state and federal legislature. Unfortunately, many medical issues are kind of politicized these days, but public health advocacy and reaching out to senators and representatives to ensure that they're using evidence-based science to make their decisions can be really impactful. And I'll actually touch more on some recent legislation later in the webinar.
So Tiffany, I agree wholeheartedly and would encourage folks to reach out to their legislators. Sometimes, I'm sure you've encountered this as a public health professional, but sometimes the legislators do not have any type of healthcare experience. Mm-hmm. Many times they don't. And they're making decisions about, you know, these policies that will affect, as you said, the healthcare of the community. And it's important that all of us in the healthcare field weigh in and try to educate our legislators. So they're needing that. And I know I've talked myself about my local representative is a car insurance salesperson. Mm-hmm. And that's great, but they have no idea about healthcare. So it's so important that I speak to them on a regular basis and help them understand what's mm-hmm. happening to me.
Yes, that's absolutely true. I'm glad to hear that. So lastly, once you've spent all that work assessing and developing your initiative, you want to make sure it's feasible and long-lasting. So evaluating your efforts for efficacy, maintaining your infrastructure, whether that includes medical supplies or employees, is very important. And of course, you want your efforts to have the largest impact possible. So equity and ensuring that your efforts aren't bottlenecked to only certain populations is always at the forefront of efforts like this. During the beginning of 2020, people all over the world kind of got a crash course in public health. People became familiar with terms like quarantining, social distancing, mortality and infection rates. But as I mentioned before, these terms and calculations have been used by professionals for many years. They weren't developed just for combating COVID-19. In the US especially, Americans became more familiar with the Centers for Disease Control and Prevention, or the CDC. But again, the CDC has been an established organization for many years, and that's had a hand in keeping Americans healthy. Their initiatives range from things like recommendations for childhood vaccinations, workplace safety, and then of course, policy development and guidance for disease outbreaks, whether that's for diseases like COVID-19, Ebola, or even the seasonal flu. The CDC was one of the first entities that guided us into social distancing and quarantining individuals who were symptomatic for COVID. But it's important to note that the CDC is a scientific entity, and so their recommendations may change as more information or resources become available. And we saw this in effect at the beginning of the pandemic when the CDC shifted to suggesting masks for general populations versus just for healthcare professionals, once those masks were more attainable on a large scale. And then we also just saw this again last week when the CDC put out a statement saying that fully vaccinated individuals no longer need to wear a mask if they so choose. One of the most prominent suggestions by public health professionals was to mitigate gathering in crowds or unnecessary contact with individuals who may be sick or carrying COVID-19, especially our at-risk individuals. We also began hearing of severe shortages of PPE, like masks, surgical gowns, and gloves. And this really forced much of our workforce to shift to a virtual workspace, kind of overnight, and that includes healthcare. A lot of the quote unquote non-emergent medical care, like elective surgeries such as cosmetic procedures or perhaps a joint replacement that could be delayed, were postponed. And this was done not only to conserve PPE, but hospital beds and available healthcare workers. And as a result of this, it's estimated that 28 million elective cases were postponed or canceled globally. Along the same lines, many patients were concerned that going to the doctor's office or hospital, places where people go because they're sick, would expose them to COVID-19. So we began to see patients avoiding medical care, a striking amount actually, 41% according to the CDC. Even more surprising, 12% of that 41% avoided seeking urgent or emergent care for things like heart attack symptoms for fear of COVID. Unfortunately, this hesitancy or delay in seeking care was exacerbated in populations that we already know are disproportionately affected by those social determinants of health that we just discussed. These types of individuals include unpaid caregivers, those with underlying medical conditions, and people with disabilities. Okay, so we have a respiratory illness that is easily spread from person to person, and we certainly don't want that, but we still need people to get necessary medical care. This is really telehealth's time to shine. Utilizing telehealth allowed people to seek care for symptoms that could be assessed via phone or video. And this is really valuable when it came to COVID-19, because if patients' symptoms were mild enough, they didn't have to go to a doctor's office or an urgent care to be seen. And that ultimately cut down on exposures to medical staff and other patients in the clinics and waiting rooms. So continuity of care wasn't necessarily disrupted, despite many people having to quarantine or socially distance. In addition to the reduction in exposure, patients were also reaping the already well-known benefits of telehealth. They didn't have to drive to a clinic, sit and wait in a waiting room for 20 minutes, or take time off of work. The combination of those benefits to patients caused the usage of telehealth to really skyrocket. And another huge benefit was that telehealth protected our healthcare workforce. When providers see patients virtually, they themselves aren't exposed, and thus they can't carry infectious diseases to other patients. So not only did our providers stay healthy, but it also ensured that they wouldn't be out sick for 2 weeks, resulting in their patients' visits being canceled and backlogging medical care in an already stressed healthcare system. And I read this statistic at the bottom of the slide recently in APHA's newspaper, The Nation's Health, and it really made me pause. If we lost 15% of our healthcare workforce, deaths in the general population could increase by as much as 1,716%. That's astronomical. And that really puts into perspective how crucial it is to take care of our healthcare professionals.
That number is absolutely huge, and I'm glad you pointed that out. I wanted to share an example. We've had a client in an at-risk population area that was initially trying to provide in-person care, and nearly immediately the entire healthcare workforce was infected. Now, some were symptomatic and some were asymptomatic, so they immediately had to take everybody back to telehealth and were able to care for patients via telehealth at that point. But it just goes to the point that you just said, if all the healthcare workers were down, even though they initially tried to stay in the office, that would have been a huge risk to an already at-risk population.
Right, and it really adds up. Some providers see 30 to 40 patients a day. So when you multiply that by, 4 or 5 providers in a practice, that can really, really add up quickly. So in my last slide, I said that telehealth experienced an exponential boom, and I was not kidding. Telehealth usage increased 152% during the last week of March 2020 alone. And following that, the number of weekly visits increased by 23-fold compared to pre-pandemic usage. Telehealth isn't feasible in all medical specialties. We absolutely need surgeons to do surgery, and we need obstetricians to deliver babies. And of course, sometimes we just prefer an in-person visit with our provider. But some medical specialties really thrived in the telehealth landscape, including endocrinology, GI, neuro, pain management, psychiatry, and cardiology. I actually work in an outpatient clinic, and our providers have been doing telehealth visits almost exclusively for a year. And just anecdotally, we've noticed a huge decrease in no-shows. So in many ways, telehealth is beneficial for providers as well. And even today, as more and more of the population is becoming vaccinated, some people are still preferring those virtual visits. Nearly a third of medical visits continue to be virtual, according to APHA. So telehealth is certainly here to stay. In addition to tried and true medical care, we're even seeing telehealth as a value in the COVID-19 vaccine rollout. Patients have been able to have easy access to their providers via phone, video, or even a secure message to discuss their concerns or eligibility in regard to the COVID-19 vaccine. Studies have shown that despite social media and polarizing news, patients still value the recommendations of their primary care providers over anything. So having a provider to explain the benefit of vaccination despite so much widespread misinformation is paramount. And although we're pushing for as many people to get vaccinated as possible, for some people, it's just not an option. Those who have compromised immune systems or who are too young aren't able to benefit from the protection that vaccination provides until we're at a level of herd immunity, which may take a long time, especially with so many people who are hesitant with the vaccine right now. So for those high-risk patients who aren't allowed to get vaccinated while the virus is still transmissible, telehealth is quite literally a lifesaver. Telehealth has allowed women to work through the risks and benefits of getting vaccinated during pregnancy or while trying to conceive. And finally, telehealth has really supported follow-up and increased compliance among patients. I mentioned earlier that the clinic that I work in has noted drastically improved no-show rates, as have many other specialties, but in terms of vaccine rollout, it's been much easier for healthcare systems to send out reminders about scheduling their second doses of the vaccine, or for patients to report side effects. On top of all of these ways that telehealth has supported the vaccine rollout, I'd argue that many telehealth providers have been constantly trying to fight misinformation. There's a lot of medical misinformation surrounding COVID-19 and the new vaccines, and especially in a world where we're now receiving so much information electronically, like while working from home, banking, ordering our groceries online, it can be really difficult for people who aren't incredibly health literate to decipher what is true and what isn't. So now we'll switch gears a little bit to telehealth and public policy. Many people think that politics is related to just foreign affairs or the economy, but healthcare takes up a large portion of legislators' time. And I'll put another shameless plug in here about contacting your legislators and letting them know your stance on healthcare issues and providing them with evidence-based science to aid in their decision-making. Like Michelle touched on earlier, many legislators don't have a medical or scientific background, yet they're the ones making laws and regulations for our medical care. And at the end of the day, we pay their salary with our taxes. So it's important to let them know your stance on these issues and make sure they have the information they need to make their decisions. The cascade of legislation regarding the coronavirus public health emergency started in March of 2020 when the Department of Health and Human Services relax some security and privacy rules to allow for the use of non-traditional methods of communication, like utilizing Zoom or FaceTime. And this was done with the intent to limit the risk of infection to people who may be exposed to COVID during an in-person visit.
So I will put a statement in about utilizing those technologies that are non-HIPAA compliant, that right now the OCR is exercising its own restraint related to the prosecution or the investigation of scenarios where people might be using non-HIPAA compliant software and hardware. So knowing that the public health emergency goes through the end of the year and that will at some point be over, we would encourage all of those that are on the phone or on the webinar today to go ahead and switch over to something that's HIPAA compliant. That's if you're currently using FaceTime or straight Zoom versus Zoom for Healthcare or something like that, make sure that you do have a HIPAA compliant software.
Yes, thank you. In addition to some of the declarations made during the public health emergency, there has been some significant legislation at the federal level. If you've had the news turned on at any point during the pandemic, you've probably heard the name of one of these three bills. The CARES Act, an acronym for Coronavirus Aid, Relief, and Economic Security, was signed into law on March 27th, 2020. And this act expanded the waiver prohibiting any clause from the Social Security Act that impeded patient care delivered via telehealth during the pandemic. It extended coverage to rural health centers and federally qualified health centers and improved the in-person requirement or removed the in-person requirements for home dialysis, hospice, and VA services during the pandemic. This act also drastically increased funding for telehealth and addressed reimbursement issues to require entities like insurance companies and Medicare and Medicaid to cover telehealth visits during the public health emergency. The HEALS Act, an acronym for Health Economic Assistance, Liability Protection, and Schools Act, extended Medicare and Medicaid's reimbursement for telehealth, and it extended the CARES Act policy that allowed rural health clinics and federally qualified health centers to continue to serve as distant sites and be reimbursed for 5 years beyond the public health emergency. And last on this slide, the HEROES Act, an acronym for the Health and Economic Recovery Omnibus Emergency Solutions Act. In terms of telehealth, this act allocated funding to develop telehealth services within Indian Health Service or IHS organizations and within Native American communities. It's important to note that all three of these pieces of legislation provided public health funding and funding to address COVID-19 through epidemiologic measures and including testing. But this is only a fraction of the legislation that's been passed to address concerns related to the public health emergency. Much more has been passed at the federal level and even individually at the state level as well. I mentioned earlier that despite the slow progression to normalcy through vaccination, nearly a third of routine medical visits are still being held virtually. I foresee telehealth being a regular part of healthcare going forward, but there are some considerations to keep in mind. Although many people shifted to telehealth easily, that progression was easier for people who were more affluent and who had access to resources like dependable internet, a smartphone, or a computer. For many low-income households, rural areas, and other populations, broadband internet isn't always as easy to come by. And in terms of public health solutions, assessing how these populations could obtain access to the resources necessary to access telehealth is going to be crucial. And while many telehealth platforms and companies strive to make telehealth easy to use, it can still be difficult to navigate for some, particularly those who aren't very savvy with technology or healthcare. So perhaps our older populations who may not be as efficient with technology may get frustrated, or those with a lower health literacy may still benefit from in-person visits. There are also some infrastructure considerations to keep in mind as we move forward. Security and privacy of patient-sensitive information has always been a huge concern in the medical field, but moving to virtual care has exacerbated those concerns, and rightfully so. It's really important for healthcare organizations incorporating telehealth into their practice to ensure that their patients' information is protected and that it can only be accessed by the personnel necessary. Professional licensing is something that isn't talked about a lot, and sometimes I even overthink it as well, but attention has to be paid to where these patients are during their visit, what their state of residence is, and if their provider is licensed in that state. Many regulations were relaxed during the public health emergency to increase access to care, but this is also something to keep in mind going forward, as many states have different licensing criteria. This is probably the third or the fourth time I've touched on legislation in this webinar. Can you tell I think it's important? But some declarations and provisions are set to expire at the quote unquote end of the public health emergency, whenever that's declared. So some of the relaxed restrictions may be retracted, and there may be a bigger push for in-person care from the federal level. And finally, the elephant in the room and everybody's least favorite part of our healthcare system, payment and reimbursement. I just mentioned that some of the declarations will expire at the end of the public health emergency. So some virtual services, maybe like phone check-ins with a provider, may not be reimbursed, or at least not at the same rate, which would cause the providers or healthcare organizations to lose money if they continue to use those modalities. This, of course, isn't feasible and would be a push to favor in-person visits again. We, of course, all want to get back to our lives as it used to be pre-pandemic, but telehealth is one concept that is certainly worth hanging on to for many reasons that we've touched on in this webinar. So as I've mentioned before, a lot of public health work boils down to advocacy and policy development, and I think we'll see a lot of that in favor of telehealth going forward because it ultimately increases access to care for so many patients. Although there are significant considerations that will need to be addressed, particularly in the legislative and reimbursement world, the benefits of telehealth as public health tools are obvious. Telehealth makes it incredibly easy to triage patients, whether that's a dentist sending out screenings to their patients 24 hours prior to coming in to ensure that they aren't symptomatic for COVID, or a telehealth provider urging a patient to go to the ER for chest pain, or urging a parent to not take their child to the ER for an ear infection and instead utilize urgent care or a virtual visit instead. A lot of times, physicians are contracted with multiple facilities, so they may round on patients at the hospital and also staff at other clinics in town. And utilizing telehealth could eliminate travel time for physicians like that and allow them to more efficiently fill in the gaps of their day rather than spending time commuting from clinic to clinic. Providers can also be quote unquote deployed. I put this in quotes because they'd be deployed virtually rather than in person, but they can be deployed to help during times of need. For instance, if there's a natural disaster and it's an all hands on deck type of situation, the providers who are physically at the site in person may be doing some type of EMS, first responder work, but the less acute patients could certainly still be seen virtually by those deployed providers. And along the same lines, it's inevitable that we'll experience a pandemic again someday. That's just how nature works. And in fact, if you talk to any public health person or an epidemiologist about this, they'll tell you that we were kind of overdue for a pandemic on the scale of COVID, since the last significant pandemic was the flu pandemic of 1918. So if and when the time comes that we experience something like this again, we're going to be much more prepared in terms of utilizing telehealth. Organizations can also save money with virtual visits compared to in-person visits. For in-person visits, the providers may have to use a lot of single-use items like gloves or sterile supplies, and the rooms have to be thoroughly disinfected between patients. And while those are nickel and dime costs, they can add up over time. So I wanted to conclude today by reiterating some of the common goals and the values of both public health and telehealth. Both fields aim to have a large impact on the health of populations while still valuing individual patient care. Both fields also aim to protect our healthcare workforce. That statistic that I shared earlier about even a minuscule percentage of our healthcare professionals being out of work, equating to an over 1,000, almost 2,000% increase in patient demises is terrifying. And I think most of us heard the horror stories of hospitals in LA having to turn away patients because they just didn't have the workforce they needed for a brief time, is something that we certainly don't want to become a normal thing. And on a similar note, we don't want our providers to become overburdened, whether that means on an organizational level or an individual provider level. We need our hospitals and clinics adequately staffed and supplied. And again, we probably heard stories about some hospitals not having enough ventilators for intubated patients during the peak of COVID. And that's burdensome not only on the efficacy and efficiency of medical care, but that kind of stress is also going to lead to burnout in our incredibly valuable healthcare workers as well. And finally, both public health and telehealth value and focus on prevention. No healthcare professional wishes adverse outcomes or hospitalizations on a patient, but we're certainly there when they need it. Through screening and identifying those at-risk and disproportionately affected populations, we can help mitigate some of those undesired health outcomes. Telehealth is really advancing in terms of remote patient monitoring, and that will be paramount to people who suffer from chronic diseases like diabetes or cardiovascular disease. So although public health and telehealth were a match made in a pandemic, I think they were always destined to have a strong relationship. COVID just kind of gave us the push that we needed to intertwine the two on a more significant level. So here is the list of references for any of the statistics that I mentioned in the presentation, along with some good reading materials on the same topic. And again, my name's Tiffany, and thank you so much for joining and listening to me talk a little bit about telehealth and public health.
Tiffany, thank you so much for sharing your public health experience and knowledge with myself and all of those that are on the webinar today and anyone that will be listening. The intersection of public health and telehealth, you can see as you've laid that out, from the social determinants of health to digital challenges that we have in variety of areas. They are effectively intertwined without us even knowing it. Even before the pandemic, that was already part of the telehealth mantra to reach more patients, to improve access to care, to not just to convenience care. So you just really touched on all the great points, and I'm smarter about public health today given this presentation. So thank you so much.
Thank you. I'm so glad to hear that. I really appreciate the opportunity.
Absolutely, absolutely. So thank you for everyone who has attended the webinar today. We do have a couple of minutes for questions. If you want to add any questions to the chat for Tiffany or myself about telehealth or about public health and the intersection of telehealth and public health, please feel free to put those in the chat. I also want to let you know that this evening we will be interviewing on the radio show that we have on a regular basis, Dr. Paul Offit, who is a professor of pediatrics at Children's Hospital of Philadelphia. And he is also on the advisory board, which advises the FDA for vaccine approval for the emergency use authorization. So a very knowledgeable physician in vaccines, and of course in the current vaccine distribution and vaccine challenges that and benefits that we'll see across the country. And then his wife, Bonnie Offit, as well, who is also a pediatrician. They are both worked at Children's Hospital of Philadelphia, but Bonnie has recently taken a role as the Chief Digital Health Officer at Self-Care Decision. So this radio show with the power couple of the Doctors Offit will be tonight airing live on air, and will be also recorded and posted on our website for future listening. In addition, the always entertaining and fun and knowledgeable Dr. Judd Hollander will be on our radio show as well. He is the Senior Vice President of Healthcare Delivery for Thomas Jefferson University, which is well known for its advancements in telehealth in particular, as well as its initiatives around educating the public and educating our new healthcare providers, our clinicians that are in medical school or in nursing school, et cetera, and educating them on telehealth. So listen to that on WATD 95.9 online tonight at 9 p.m. or pick it up on our website later in the Knowledge Tsunami, where you'll find articles, other webinars, and lots of other information, other radio shows that we've done and guests. So this will be a great radio show tonight. So we hope we will see you.
A really good augmentation to the public health topic.
That's exactly right. Yes, that's right. It'll dovetail right into what you've discussed today. Tiffany, thank you again for doing this webinar. Again, I'm smarter about public health because of you today, and so are our listeners and attendees at our webinar today. So thank you so much. We look forward to hearing you and doing another webinar with you in the future.
Thank you.
Thanks everyone for attending. If you have any questions that you want to send directly to Tiffany, she shared her email address. That's tiffany.johnson@blue-cirrus.com. Thank you so much for being here.
Thank you.